त्यो देखाइरहेको छ यो कुन पेज हो पेजको नाम के छ
देखाएको छन् है
पेज नै देखाएन कुन हो पेज पेजको नाम हो
यसको नाम कहाँ गर्नु
नमस्कार
हेर्नु पर्ला अडियोबाट त्यहाँ चढायो त्यहाँ हाल्नुहोस् अडियो त्यहाँ लाइभ आउनु भएको नि रेकर्ड नगरी डाइरेक्ट टिपिरहने अहिले एक्सेप्टिङ हुन्छ खोपी भएछ अहिले त एकजना आउँछ अहिले हेरेको हुन्छ
अनि यो मान्छे
सक्छ ए सक्यो मलाई चाहिन्छ पेन्टअप म आएँ त कहाँ खानुला
यसपछि एउटा प्याकेट हाल्यो ल
यहाँभित्र त के बोलेको छ हामीलाई नै मोन्टो जान्छ
मोन्टो त छैन हुन्छ
Clicker. रुपेश क्लिकर देऊ त होला
So some people are used to using this fluid pump. However, I use the gravity method. I placed a hook up in the ceiling, and I use just to the lower ones. This is the Medtronics system where we have this fluid pump by the side. The aim is to maintain the pressure of 30 to 50 mm of Hg at the Sons space. Unlike in the knee and shoulder, we have a void, a dead space there where we make use of that space. But in spine, we have to create that space, and the space optimum pressure that has to be maintained is 30 to 50 mm of Hg. So this is the in this picture, the second picture, we can see the blue area, that is the Sons space created, and this on the gravity meter, the gravity assisted is around 100 centimeter above the head level, surgeon's level. It has a roughly formula also, divided by 1.36, it gives the pressure around it. The other instruments used are serial dilators for the working portal and the scopy portal. Starting from the 5 mm, 7 mm, we serially dilate it after marking. This is the T-handle used to detach the muscle from the lamina. The one is a scope retractor, scope sheath or scope retractor used with the scope. The second picture shows the working portal sheath. This plastic cannulas are popularly used by Park sir, and he gave me this cannulas, and dissectors. These are handy because they are long and we can use easily. Dural root retractors. This is the metal suction used at the last of the step of the discectomy. After removal of the discs, we do the disc wash with this. Keresan punch, in UB the normal ones are commonly used. Curved one useful for lateral recess foramen, undercurtain lamina and partial facetectomy. The curved rotatable punch have better access in difficult areas, better angulation, improved visualization. They are shaped near neural structure, useful in both interlaminar and transforaminal approach. They have improved ergonomics and less instrument crowding, and there is less instrument exchange with that. Pituitary forceps, straight and angled. These are used for removal of the tissue and the discs. Other set of instruments are osteotome, both straight and curved, used for facet release, and even the lamina, taking down the lamina, we can use this. Another one is this one is the Indian knife. This one is used for annulotomy to remove the discs from the inside. So another part of my presentation is the basic steps of UV discectomy. That is patient positioning, marking portals, working space creation, laminotomy, flavectomy, and discectomy. So this is the OR setup we need to achieve. We need to do. The surgeon sitting on the left side, the instruments on the right side of the surgeon. The monitor, video monitor on the at around 11 o'clock, 11 o'clock. The CM monitor on the 2 o'clock. We achieve hip. We have to achieve hip and knee flexion, abdomen to be free, Foley catheter, well padded bony prominences, endoscopic drape, and just beneath this, I'm using this Meyer trolley to keep all the instruments set just beneath this, above the leg of this patient positioning. So next step is the marking. Under C arm, we mark the midline. We mark the. We achieve the true AP image of the patient, and then mark the midline, in plate, and pedicle. The starting point for the discectomy, it's a medial pedicle line. For stenosis is the mid pedicle, and for fusion is the transverse process. And under image, I'm used to giving this local anesthetic, diluted ones to achieve the hemostasis. So I prefer horizontal incisions, instrument portal dilating up to 8 to 10 usually as required. Thoracodorsal fascia incised obliquely, not usually obliquely towards the spinal laminar junction. Serial dilation, scopy portal around 5-6 mm as the scopy sheath is placed. Two portals usually around 2 to 3 centimeter in distance, and after confirming the level, we put this instrument. We have to confirm this level on both AP and lateral view to avoid the wrong level surgery. So creation of a working space, that is popularly called Sons space, muscle detachment from the lamina by the T handle. I'm used to doing with the scalpel also, the back end of the scalpel. Coagulation of the bleeders, soft tissue and superficial phlegm removal with the punch. Continuous saline flow before laminotomy. Here we should appreciate the flow of the water flow. There is no inflow. Phlegm from the starting from the upper lamina, lower part of the upper lamina, release from the inferior articular fasciate process, release from the upper part of the lower lamina. Usually, sometimes we burr down the upper part of the lower lamina, and at the I use the curate to release that after partial taking down the upper part of the lower lamina. Knob hook or prop RF to release dural attachments, and removal of the phlegm in total, that is butterfly right here, or in piecemeal. I'm doing piecemeal till now. I am not able to achieve the whole of the ligament phlegm release in total. So the final part is the disc space localization, that is medially to the superior articular process. Sequestrated disc freed with the probe, removed with pituitary, annulotomy with Indian knife, free disc removed from inside, and wash. Final step is wash with the cannula. These are some of my cases. Right-sided L45, I approach from the left side only standing. After marking, I've removed all the discs. The root and the central canal are well decompressed. We can appreciate in this video. This is another case, 45 years male, left lower limb radiculopathy with the neurology, both central and lateral recess, even bilateral, more symptom on the left side. So I had to decompress both contralateral side also. This is another case. 35 male, left lower limb radicalopathy. After marking, the removal of the disc. And complete decompression. Thank you.
Thank you, Dr. Tej. That was a wonderful presentation. If there is any queries, we will take queries from the floor now. Okay, I don't think so there is any. Thank you for your wonderful presentation. Please,
Thank you.
Dr. Tej, I will request Dr. Balgopal to give him memento and certificate of appreciation. Thank you. Now I would like to call upon Professor Amit Thapa. He will be talking on hydrodynamics in UBE surgery.
Thank you, chairpersons. Okay, can I have the screen here? Yeah, okay, thank you. I will be talking today regarding why we are doing some things in the UBE. Well, until unless we do not know this answer of why, we will not be able to decide what to do and how to do. And that's why this question of why we are doing things in UBE and what is being taught since this morning is the thing which we are going to discuss in the few minutes from now. At the outset, let me congratulate the newly built Nepal Endoscopic Spine Society for bringing together all these spine enthusiasts who are into endoscopy, and I think this is a way to go for ahead. And I'm grateful to all the foreign faculties to have come all the way here to support this newly built society, and we wish them all the good luck for the future. Well, I have nothing commercial to disclose in this presentation. I am blessed with very learned friends and mentors who have taught me all this way through my journey in spine endoscopy. To begin with, the only technology which I see now, which has stood the test of time, is a safety pin, which the ladies use more often, and we males actually look at it and just wonder how this technology has actually continued over the last 176 years, with despite of continuing its shape and format, it still finds its use amongst us. But then, unfortunately, in our practice, this is not the story. We keep on changing. I was trained as a microscopic neurosurgeon. We did many hemianemolectomies to reach the interdural pathologies. But then there was something which was required, good illumination, good work inside the corners, and that's how we started doing Destando system in 2014. And since then, we have been doing a lot of intradural and extradural using Destando system, but again, there was something lacking. And the lacking was how to go into the nook and the corners. Even though this was a mobile system, the chances of maneuverability inside the cavity was far more lesser. So even though we could actually receive a good decompression, can remove the disc completely through that particular port, there was something lacking, and that's why we started doing UBE, and because of this ease of maneuverability, we could actually do a lot of things with the UBE technique, and now we are using a fusion technique. We are using UBE with MIS to approach even intradural pathologies. Well, now we are doing a lot of UBEs, from decompressions to single level fusions to even multiple level fusions, and as we all know, universally we are finding very good result. Patient can walk the second day of the surgery, and of course the happiness on the face of the patient is far more satisfying. So the first principle we are going to talk about is the principle of triangulation, because this is something which is all required for UBE. We need to see the tip of the instruments in the depth, and that's what we have to identify what would be the perfect target. Because when we leave the open triangle, we will not be able to see the instruments. When we come very close, then of course the instruments will fight with each other. So that's why we need to have an idea as to where the perfect triangle would make. So before we start the procedure, it's always mandatory to use at least 2 hypodermic needle and see that particular triangulation happening over the spine on a lateral X-ray before we start on the making the port. Second one is a visualization. As the previous speaker did say that the 0 degree and 30 degree has its uses and advantage. 0 degree is actually an extension of our microscope. Only thing is that we are actually going near to the target. But what 30 degrees gives you is a good expanse of vision, because now you can rotate the endoscope inside and can have a good field of view, an expanded view. But what we need to know, okay, so they will keep on working on that, but then what we need to know about the 0 degree and the 30 degree is that the 0 degree can actually give you vision in the ahead. So that's why the depth perception is far better in the 0 degree. But when you use a 30 degree, if you are looking towards your instrument tip, always be cognizant of this fact that the tip is not towards your target. The tip is actually above the target. So you may be trying to bite a tissue, but since you are using a 30 degree scope, the depth perception would not be better. It's still not playing. Okay, so I can actually play with this, no problem. Okay, so the point I was trying to make was that if you are using a 0 degree scope, you can actually see the tip. So that perception is far better. But when you are using a 30 degree scope, you are looking actually upward. And that's why the tip is never towards your target. So we may try to bite on the tissue by using a 30 degree tissue or 30 degree scope, but then actually you are not on the target. That's why you are hitting on something which is not there. Similarly, when you are actually looking away from the target, away from your instruments, then you are looking down. And this is a very risky period, because your instrument, when it is coming from backward, can be actually hitting the tissues which is at the floor. So these are the few concepts one should be cognizant about when you are using 0 degree and 30 degree. So usually we use 30 degree whenever we are going to go for a contralateral approaches, when we are doing a facetectomy on the upper side. So those are the angulation where we require 30 degree. Otherwise 0 degree is good way to start with and then build upon your cases. Now the other thing which I'm going to talk about is the fluid management, because it is all about the fluid technology which we are using in UBE. We all know the fluid medium. We are using a normal saline in the normal temperature, room temperature. The height of the inflow, which we have already discussed by the previous speaker, had been a 1 arm height from the surgeon's head. The optional way is to keep a set pump at around 25 millimeter mercury, and some literature quotes that even you can go up to pressure of 40 millimeter mercury. But point to note is that every time when you increase the pressure, all the pressure is going to get transmitted through the dura into the intracranial space. So the ICP goes up, and since a patient is lying prone, all the pressure gets transmitted to the eyes. So these patients can develop temporary headache, temporary blindness, headache, and even visual loss later on. So the key to is to maintain your ligamentum flavum unless you are using, if you are using a high pressure. The moment you are doing a flavectomy, then you should not create the pressure more than 25 millimeter mercury, because that's the safest. The literature has not quoted any case of blindness or any post-operative problem if the pump pressure is not more than 25 millimeter mercury. So 25 is the key when you are working underneath the flavum. Then we have talking about the ingress. As we all know, in the biportal we have a scope port. So through the scope we have an ingress of the fluid, and then through the working port we have a egress of the fluid. So we use a semi-tubular system because it does not prevent allow a very high built of pressure inside the cavity. Now why do we need a fluid? Well, the major use of the fluid is to create a space, as the zone space has been discussed earlier. So it elevates the paraspinal muscle above, and that's why it creates a working chamber. Mind you, even though under this endoscope the space may look big, this space is still lesser as we create in the MIS approaches. So this space is still not that much bigger. Then it provides a constant irrigation. It clears visualization, improves magnification, and prevents infection, and this has been documented in literature throughout. The other important thing is the cooling effect. It dissipates the heat, and this study has actually showed that if you are not using the proper fluid management, within 1 minute of starting the treatment, your temperature inside the cavity goes above 42 degrees centigrade. However, if you're using a fluid management, the temperature can remain between 23 to 24 centigrade. So this is much more safer when you are using it. Then it provides hemostasis, because we all know epidural venous bleed stops beyond 15 millimeter mercury pressure. So just 25 millimeter mercury pressure inside the cavity can be good enough to give you a good bloodless field inside it. And as Dr. Wang was putting up, we should always try to keep an irrigation which actually throws water in the forward stream, because this pushes the dura. That's why it protects you from any dural tear, and it creates an environment for plasma RF, because plasma RF requires a saline environment. It requires electrolytes to build. So this plasma actually forms at the tip of the RF probe, and this can actually help you to maintain a coagulation as well as ablation without causing any injury to the nerve. Now regarding the fluid dynamics, which we all have to create a stable and safe water dynamics throughout the surgery, the first principle we have to understand is the Pascal law. So when we say Pascal law, we all know that the pressure is equal to the height of the water column we have created. It is not related to the shape, it is not related to the volume as such which is there inside the cavity. It is the total height. So the height which you are actually putting the water ingress from above is all transmitted down. And again, to reiterate this fact, the lowest point where the patient is going to be affected is his eyes. So that's why we have to be careful of this particular fact. And then this particular dynamics is used not only to create and maintain the space for the work, it also maintains the patency of the port. So once your water goes inside, you will immediately realize that your ports are well maintained. You don't have to struggle to again go inside your instrument port times and again. And then you have to create a fluid management system, and it creates a good hemostasis by actually stopping the epidural bleed. Then there is a beautiful paper by Hong et al. Who have studied what actually affects the hydrodynamic pressure inside the cavity, and what they have found out is the use of pump and the obesity of the patient. These are the two important factors which increases the pressure inside the cavity. So once we are using a tube to egress the fluid out, the pressure inside is far more less as compared to the surgeries where we are not using any tube. Similarly, if the patient is obese, the pressure is much more higher. So these are and then also the length of the tube. So if the length of the tube is far more longer, the pressure is lesser. So these all things can actually decide upon the hydrostatic pressure inside the cavity when you're working through it. The other principle is the Bernoulli's equation. So when we say Bernoulli's equation, it says that the combination of static pressure, dynamic pressure, and hydrostatic pressure is constant. But what it means to a surgery? It means that whenever you increase the velocity of the fluid inside your cavity, the hydrostatic pressure is going to go down. And this is very, very important to understand, because when we are using a suction, this is a very simple example, suction creates a velocity of the fluid inside, the movement of the fluid inside the tube, and that's why it decreases the hydrostatic pressure. It creates a negative force by which it pulls all the tissues inside it. So this is the Bernoulli's principle which we are using for suctioning. And similarly, when we are in a very dilemma situation, like a patient is having a bleeding inside the cavity, what is the first response we do? We increase the irrigation, which should not be done. Why? Because when we are increasing the irrigation, it decreases the hydrostatic pressure, and that's why it will not cause stopping of the bleeding, it rather increases the bleeding. So the idea is, whenever the patient has bleed, stop the egress of the fluid, and immediately the hydrostatic bleeding from the epidural sinus. Similarly, many instrument designs are made like this, following the Bernoulli's principle. Then the third principle is the laminar flow. So when we say laminar flow, it is the very pacified movement of the water inside the cavity, and this is usually disturbed whenever you are using a drill. Now, as neurosurgeons, we are very much speed. We should not be used inside this cavity. We should keep the pressure rotation to as low as around 8 to 10,000, because that is good enough, and then use a diamond bird to have a lot of drilling space. So now you can see I'm drilling inside the cavity, and there is absolutely good vision. There's no loss of vision anywhere. Similarly, the irrigation system, the trocar design, and expansion of the operative space also follows these laminar flow principle. Then the basic problem of bleeding, because bleeding is something which we all deal with during the UB surgeries. It obliterates the vision, and in this hastiness of controlling the bleed, we use diathermy, which can cause nerve injury, and the irrigation itself can prolong the surgery, can cause hypervolemia and tissue edema, and it frustrates the surgeon because of the prolongation of the surgery. So to prevent it, always check the coagulation profile, stop all anticoagulants, use abdominal. Here I like to make a point: do not make too much of facial punctures. This usually occurs when we are putting an instrument without any port. So your instruments will always try to find another new facial entry, and this creates a lot more facial opening, and it actually dissipates all the hydrostatic pressure which has built up inside the cavity. So try not to do that. So exit pole should be always be made smaller as compared to the visual pole. And of course, while trying to achieve this bloodless surgery using all this principle, there is a caveat we need to always understand, that if we increase the flow of the irrigation, it is going to flush off all the platelet plugs. So this is something which we need to understand. And of course, the irrigation will hide the epidural bleed. So once you are done with the hemostasis or the surgery, it always makes it a point to stop the irrigation for a while, see if the patient is having any ongoing bleed inside the cavity, and if you have doubt, leave a drain. This is much more safer, because the cavity or this is so small. If the patient has a bleed, this can have a symptomatically effect on the patients. So even though the bleed may be small, because of the small cavity, they cannot accommodate large amount of epidural hematomas. Now, we have already seen how to control bleeding. Regarding the irrigation pressure, we have already discussed about that. So we close the egress first of all, we control the vortex movement, and then we can always increase the irrigation pressure by elevating the height of the irrigation tube. Now, we should also understand the disadvantage of using the fluid inside the cavity. So it can cause blurring of the vision if in case the hydrodynamic principles are not followed. It can cause excessive pressure, which can actually transmit into the neck and cause severe neck pain and headache, can cause convulsions. Patients have been reported to have temporary blindness and visual loss, and post-operative numbness is seen in those patients where the pressure had been much more higher, particularly to the sacral region. And in some cases, particularly in the para-UB approaches, if you are actually going into the retroperitoneal spaces, patient can develop a retroperitoneal collection of fluid, and which can cause pressure over the IVC and poor cardiac filling, can have muscle edema, abdominal distension and discomfort. And of course, post-operative oozing of the fluid can still come if in case you have not drained the fluid out before closure. Now, this is a very important point I would like to highlight, is the hidden blood loss. This is something which we surgeon never considered, because the surgical field used to be so clean. We thought that the UB is a bloodless field, so that's why the patient is not having blood loss. Now, this paper has actually studied the visual blood loss, visible blood loss, and have tried to calculate the hidden blood loss. And what they have found, that to a tune of 7.9%, that is almost more than 2/3 of the total blood volume loss, is the hidden blood loss. So this is not so small. It is a significant amount of blood loss. And this usually happens if we have a longer operating time. If the patient is having a paraspinal muscle thickness, the patients can have a very high risk of hidden blood loss. So this is again one concept one has to understand before they embark on surgery. So to conclude, science of optics, visualization and hydrodynamics are key to success to a safe and effective UBE. Irrigation during the UB and spine endoscopic surgeries are beneficial, but of course we should be cognizant of all these risks which is involved along with the pitfalls. And using this principle helps us to maintain a space, clear debris, hemostasis, and avoid complications. Thank you for your patience listening, and again I would like to extend all the warm invitations to my faculties here and participants for the 5th International Conference of NASON from 13th to 15th November in Kathmandu. Thank you.
Thank you, Dr. Amit. So if you have any questions to him. So I have a question, like, what is the systolic blood pressure you try to maintain during this surgery?
So nothing specific, it's just for in general condition of the patient. So we try to maintain the systolic blood pressure of around 120, 120,
Yeah.
that will be good enough.
So, and some people use also like adrenaline in the irrigation fluid. Do you use that?
No, because it can dissipate it and can go to all other areas. So if in case I have to use adrenaline, I will use adrenaline in the first go itself before we start irrigation.
Okay. Okay, thank you. So I ask Professor Yang to give the token of love to Professor Yang.
Now I would like to call Dr. Avijit Verma for his presentation in intraoperative hemostasis in UBE tips and tricks.
Very good morning to everyone. So I want to first thank Dr. Nikunj, Dr. Bhargopal sir, and all the team behind this conference. And by the blessing of Lord Pashupatinath, we are finally here, and that this conference is finally happening, which like I thought it's not going to happen, and I was really disappointed in it. Thank you so much for having me here. No, this is the very basic topic, and I chose this topic because initial phase of my learning, I've really struggled a lot controlling the bleeding, where the bleeding is from, how to manage, and most of the time when I converted to open during initial surgery phases was because I was not able to find the bleeding point from where the bleeding is. So as you can see, bleeding is one of the main challenges we have in the initial phase, even in the advanced phase also. As you can see, the multiple papers, they quote the second most common complication is the bleeding, that is hematoma formation. And effective bleeding control is a non-negotiable thing. Now, as we can see, there are the sites from where the bleeding can happen. It can happen from skin and paraspinal muscle, the Bateson plexus, which is a venous plexus over the dura, and the segmental arteries, which is rare, but it can be notorious, and the bone bleeding, that is from lamina and the facets. So why hemostasis is important? It is important for visualization, safety, and efficiency. The clear field is the basis for UB surgery. For safety, in the bloody field, in the red screen, we are not able to identify the structure clearly, and there is always a risk for neural injury. Efficiency, it reduces the time of surgery and the fluid use overall. And also the post-op outcome, it improves because the risk of hematoma formation, infection, and reoperation are greatly reduced. So which are the factors which increases the bleeding? So these are the pre-op factors in which advanced age is been reported in many papers. Obese patient, obviously we have to travel a lot, putting a port through a thicker muscle and skin, and anticoagulant and antiplatelet treatment. Also the thick muscle, patient having thick muscle can lead to increased bleeding risk. Osteoporotic spine, even in hypertensive patients. Intra factors, poor positioning. If the abdomen is not free and the abdominal pressure is not reduced, it can lead to venous engorgement and the bleeding. And poor port creation, multiple facial punctures and port at the wrong position and struggling with the port. And using a high pressure pump, pressure going more than 40 mm of mercury, high intra blood pressure, and multi-level surgeries, severe stenosis with vascular engorgements. So what are the pre-op plannings we can do to reduce the risk of intra-op bleeding? We can check the coagulation profile of the patient. We have to correct the INR and the platelet count. We have to review the antiplatelet and anticoagulation history of the patient. This is the European Society of Anesthesiology recommendation. As you can see, in most of the cases where there is a minor or low bleeding risk, we can either stop the anticoagulant and antiplatelet just 24 hours or 48 hours before the surgery. Also, it is always good to map the anatomy on MRI and the CT scan before going to surgery to have a judgment of how thick the muscle is, and to have how to plan the port specifically for that case. Also, pre-op availability of your RF hemostatic agents, bone wax, thrombin, and Flowsil should be maintained. Now coming to how the anesthesias and the positioning help us. The controlled hypotension we can achieve intraoperatively, where we can keep the mean arterial pressure between 60 to 70 millimeter of mercury, and the systolic blood pressure between 90 to 110 millimeter of mercury. Prone position with free abdomen, it really helps us. Also maintaining normothermia, because in the initial phase, you might struggle a lot, and the surgery can last up to like 3 hours or 4 hours also. And if the draping is not good, the patient will get drenched and patient will land into hypothermia leading to a coagulation cascade. And also the PEEP pressure. Usually we keep the PEEP pressure below 20. Now coming to the irrigation and instrument. Now continuous saline irrigation is the central to UBE, and if the irrigation is not continuous, the pressure will build up and it lead to hematoma formation later. This video is not playing. So this is the flow. This is called as a fountain sine. The continuous flow, it is very much needed for UBE surgery. No pump, only gravity can work. Gravity provides enough of pressure for you to perform a good surgery. Also, as many speakers before me have mentioned, cutting is only for skin and fascia. It is not for muscle. Muscle needs to be split with the blunt trocar. Also, RF with different probes should be available with us. While using the RF 90-degree probe, we should always maintain a point that the RF should be used over the bone, not in the muscular plane. Excuse me. The videos are not playing. Okay, thank you. So here all the work, all the coagulation work should be done over the bone, not inside the muscle plane. Now, what we can do if we get into such situation, the stepwise intra-op approach, what we usually follow. First of all, do not panic. We always have an option to open the case, as we are very much aware of the microscopic surgery. So first, foremost thing is to identify the source, whether it is from muscle, whether it is from bone, or from venous or the artery. The video is not playing. The clear field. Before going for any coagulation, we have to have the clear field. What we can do is, first, if we identify a bleed, either we can, as in one of my initial cases, as you can see, I thought the bleeding is from the bone. But as we proceed during the video, the bleeding was actually coming from the muscle side, which I'll later controlled. Here you can see the bleeding is actually from muscle, and I was like misguided. It is coming from lamina. So the mechanical control with tamponade with cottonide, it can help you to contain the bleeding for a moment and identify the areas from where the bleeding could be arising. And you can go at a pinpoint place and coagulate the bleeder. Also the thermal control, the RF can be used for the venous bleed. Topical hemostatic like Surgicel, gel foam, which we routinely use in our neurosurgical practice, can be used for hemostasis in these cases. In bone control, the bone wax can be used, or directly we can use an RF to control the bleeding. If it is an arterial blood flow, it could be pulsatile, and there could be like heavy flow through the artery, and in such case we can consider for conversion to open surgery. So for creating the muscle port initially, we can use an ADR containing local anesthesia, which can reduce the bleeding. Also, there is no cutting principle. The muscle should be split. If in case you happen to have any subcutaneous bleed or muscular bleed, it can be controlled just by compressing with a gauze, or the superficial bleed, we can just cautery with a bipolar. Now, if you have encounter a bone bleed from mostly from the lamina, the 3 faster maneuver which one can do is, you can either directly run the diamond burr over the bleeder points from there. It stops the bleeding. Also, you can with your instrument, you can grasp the bleeder, put a pressure over it, so the blood vessel gets squeezed into the spongy bone and the bleeding will stop. And you can also use an RF at a lower setting. So this is one of the video I found, and how they are applying the bone wax over the laminal bleed. And in spite of doing all this thing, if you feel there is diffuse bleed happening, then there is a time to check the hemodynamics talk to your anesthetist. In case of venous or epidural bleed, I usually go with an RF, or if if in a severe stenosis cases, there usually you find very congested vessel and they bleed copiously. So there you can use a patty for tamponade, and slowly you can cauterize the venous channels. Also, you can use a surgical flow seal, and warm saline also helps with tamponade effect by closing the egress. And in case of diffuse bleed, diluted adrenaline infused saline can also be used. So here is one of the bleeder I'm trying to handle. It is the epidural bleed. So if you can notice, like I am going towards the bleed, so that my flow pushes the bleed away from the camera system, and I have pinpointed it, and now it becomes really very easy to control the bleed. Arterial bleed, as I've already mentioned, it can be pulsatile and high flow. Immediate identification and coagulation is the key. If uncontrolled, then you can use a tamponade and with a patty and irrigate, increase the irrigation, identify the bleed, and go for an RF. If it's not possible, don't hesitate to convert to open. Now, as Amit sir has already mentioned about the hidden blood loss, which is very underestimated thing. Many papers, they have mentioned it to be around like 30 to 50% of total blood loss. The causes being the irrigation, it dilutes, and that's why we underestimate it. Also, the blood gets diffused in the paraspinal muscle. So these also, like, we cannot identify. Also, the hemolysis and extravasation into the tissue spaces leads to hidden blood loss. What are the risk factors in these cases? It is a prolonged surgery, multi-level surgery, elderly patients in which the blood vessels are very fragile, and also patients on antiplatelet and anticoagulation. So in the post-op period, how the patient will present, his hematocrit will fall, patient will be having a low BP, postural hypertension. These are the findings patient will have. So these are the few hemostatic adjuncts we can have in our OT, which are very useful, like the regular gel foam, oxidized cellulose, flow seals we can use. Also the adrenaline mixed saline, RF and plasma is a go-to thing. So coming to the post-operative care. So ensure before closing, ensure the hemostasis is absolute. For this, you can just reduce the flow or reduce the height of the saline bottle to see where the bleeding is arising from, because the pressure can really impede the bleed, and it can make it difficult to identify the bleed. Also, put a drain if surgery has been long or if you have any doubt. Post-operatively, a normotensive environment is to be mentioned. Usually what happens, during extubation, the patient's BP tend to rise, and it can open the platelet plug and lead to the bleeding, which can remain unidentified unless and until the patient presents with some symptoms. Also look for neurological deterioration in post-op period. Regularly check at the suture site, any redness of the skin, any pain, patient complaining any pain at the local site on the day 2 or day 3 of the surgery, you should be aware of what is going on. So the take-home message is, you should optimize the patient before taking for a UB surgery. You should optimize the irrigation, the level at which it should be there, and how much saline is to be there. Also, use RF whenever required, and it should be done proactively. If you notice any bleed, you should proactively go and stop the bleed first and then proceed. And don't be shy to call for help. The help always bring you out of the difficult situations. And don't be afraid to convert to open. Thank you.
Thank you, Dr. Abhijit. It was a wonderful presentation. Thank you for sharing your knowledge in controlling blood bleeding. If there is any question from the floor, Dr. Suresh, please give him the mic.
Will you avoid those bleeding by prophylactic cauterization of those veins, or you just separate it from the disc space?
No, I tend to separate it, and if there is any bleed, then I go for a proactive thing. Unless and until it is coming in the way of my working space, that is over the disc area or over the facet area, until then I don't go and irritate them.
All right, any more questions? Okay, thank you. I'd like to ask Dr. Balgopal to, Dr. Yang to hand over the token of love and certificates to Dr. Abhishek. Okay, our next presentation is from a dear friend of mine, and he's a very good guy, Dr. Atmaranjan Das. If we are, please let me know if we are online. Are we? We are playing a recorded version of his presentation, and you will be sitting online in Google Meet, so he can hear all of your queries after his presentation and your comments, and he will be able to answer them. Thank you.
Hello everyone, regards from Bhubaneswar, India. Best regard to Dr. Nikunj for a wonderful UB conference at Nepal. So let's discuss my topic, which I call as midline biportal endoscopy. I do not do unilateral biportal endoscopy anymore. I do it from midline, which I call as midline biportal endoscopy. And let's discuss what is under the cave work and what is the difference between over the top decompression from multi-level canal stenosis. So we know laparoscopic surgery uses multiple ports. That is for the ease of the surgery, because you are using both of your hands and one hand is not stuck to the other hand like a monoportal surgery. So it is more versatile. You can do, when monoportal surgery is a target oriented approach, here it is a more of an exploratory surgery which is needed for a multi-level canal stenosis. That is what we are doing here. So if you ask me why biportal, I say moving beyond discectomies. Discectomies can be done with any of the portals, even with the MLD has best of the results and gold standard. So we are not here to discuss about discectomies, which is a very easy procedure which can be very well done with a biportal endoscopy. But what beyond discectomy is multi-level canal stenosis. Those are the elderlies who are coming to you and asking you, can you cure me? Is there a solution with ultra minimal invasive spine surgery without putting a screw on my back? You know how painful the screws is, and now the whole world is behind putting screws, making those alignments, and 70 years spine, which has taken a God's course of little degen scoliosis, which just need a neural decompression. It doesn't need your fusion, putting screws. Patient cannot bend. And the elderly female is not able to enjoy the next day of surgery. So then we had this biportal. So if you show this to your patient, can you believe which surgery they will choose? A barely visible scar and this big scar with a 1 liter blood loss. That psychological safety with the patient is gone. They think they are going to get butchered, as if they are going to get some punishment. And once you show them this scan, they just see the psychological safety goes to the next level. They feel, no, it is not going to be a big surgery on my back. We say there won't be any blood loss, because definitely it is a saline advantage of the saline medium surgery. So if you go to the portal scopy and all, you can see this is a monoportal scope which has a very small camera, but in biportal the camera is bigger. So you see better, you get more pixeled image in a biportal endoscopic surgery than a monoportal surgery. And your instruments are not stuck to the system. So when you work with a monoportal scope, the instruments and scope is like this, one after other. So they move like this to see each other. So there is a big blind spot in a monoportal scopy, but in a biportal scopy, this goes like this. So you see each other very well, very well. There is no blind spot. So you work better with this. You see the scope in a monoportal surgery, it is very large, and this is very small scope. So it can go under the cave like a drone and making the surgery successful and accessing those blind spots which are previously hidden, and we call endoscopy fails. Endoscopy fails because of these blind spots. Now we go to this video. You can see how the scope moves. The scope moves like this is just a simulation of the drone shoot which I am taking here. You can see the scope is going like under the cave, and this is the nerve root which you can see here. This is a nerve root. This is just a simulation. I wanted to show you how it works. Now we go to this video. You can see how the scope moves. The scope moves like this is just a simulation of the drone shoot which I am taking here. You can see the scope is going like under the cave, and this is the nerve root which you can see here. This is a nerve root. This is just a simulation. I wanted to show you how it works. So now if you go and try to understand canal stenosis, this is the image where we understand why endoscopy fails. Endoscopy fails because you make the decompression incomplete. Now most of us, whenever we do endoscopic surgery, we see the traversing route and we show how the traversing route is released. But in a severe canal stenosis, it is not only the traversing route which is that compression. We never see the exiting route. That we have to understand and accept. Now if you see the 4 quadrants, if you achieve a better decompression when you release all these 4 quadrants. But what we do, we release just these 2 quadrants, just these 2 phlebum, and the upper phlebum till here we remove, and this rest of part is left behind, causing the exiting route compression. That is why they come with a claudication distance of 30 meters. You operate, they go back with a claudication distance of 200 meters. Why not 2 kilometers? That is why we discuss about this biportal and under the cave work. This is what we decompress, but this is because this is what is seen. But this is what is the original picture. You can see how up it has gone and compressed it. So this phlebum which is near the exiting route is the reason why biportal endoscopy fails. So you see this scar, how tiny it is. So with this newer dimension, we don't use a bigger dilator than 6 mm. So my incisions are much smaller than the traditional biportal endoscopy. And you see the incisions are in the midline. So we call it midline biportal endoscopy. So if you see this image, so this is the image. You have to understand what is midline biportal endoscopy. So a midline is not a line, it is 3 lines. One is a midline, other one is a left midline, other one is a right midline. So it has been a debate, if you have a right-sided pathology, what you are going to do. So definitely people will answer, we'll go on the right side, we'll change the ergonomics of the OT, your ergonomic, your psychological, mental ergonomics, and you go on the right side. So but it is cumbersome. So what we have designed with midline biportal endoscopy, because this is nothing, just the lateral border of the spinous process. We don't stay on unilateral side, we stay in the midline. What is the advantage? You can access both the corners of the left and right side easily from the midline. It is of equal distance from the midline. Now you can see this is a multi-level case, and suppose you have a left-sided disc, you dock it from here. You have a right-sided disc, you dock it from the right side, and you can see all my incisions are made on the vertical incisions because I do jump-in technique. So suppose I want to operate 3 levels from a single incision. What I can do, I can jump from here to the other level, then go back and operate on the same level, then go down and operate on the other level. So by just 2 incisions you can operate till 3 levels, which is very easy with midline biportal endoscopy. And these are my instruments which are very small, so you can do the surgery very fast. So this is the caver's work. Cavers go like this. So before that we understand what is a blind spot. This lorry man sitting and driver is sitting and seeing on the rear view mirror, there is nothing visible. Like open surgeons or the oldest generation endoscopy surgeons, nothing is there. under the lamina and explore those areas which are causing compression. This is what we need to see. This is a multi-level case. You see, these are 5 levels. So if you see the scan, these are the markings and the levels. All are 4.5, 3.2, 5. So we did a canal stenosis, and these are the ports. How small is the ports and multiple drains. Similarly, we can operate any level we want with a biportal endoscopy, and this whole duration of surgery was 1 hour 45 minutes, a 5 level. So we do the surgeries very fast with midline biportal endoscopy. I use a 0-degree scope for the surgery. So you have, for this you have to understand this telescoping. This telescoping is actually, which is the reason why we do under the cave. Under the cave is for this blind spot. You see the thecal sac, what is the lateral border of decompression? You see, it is not the lateral border of the thecal sac. It is few millimeters beyond the thecal sac where this blind spot is. You can see this flavum sitting there. You can see this snake-like flavum sitting there. If you don't remove this, the patient is not going to improve. Or they will improve temporarily, but they won't get that amazing claudication distance of 2 kilometers, 3 kilometers if you don't do this. This scan, if you understand, you will understand what is a blind spot. If you see, there is a wonderful decompression from here to here, but there is a problem. The patient was operated outside with a 30-meter claudication distance. He came to us with a 300-meter claudication distance. He said, I didn't have that improvement. I improved, but it was not that improved. Then we tried to see the scan, and we can see there is a blind spot sitting which was never removed. You see this scan, people putting scans in the social media, you see multiple wonderful decompression, but if you see here, there is a compression which is sitting there. If you compress it with a thumb or the fist, it does not matter. It just the compression you have to release, and this is the caver's work. This is the cave, and this is what we create. And if you see the scan, this is the splitting which we have done and enlarge the size of the canal with this. So you can see this lamina, this is split into half. This is the caving which we have done for the patient. With this video,
let's discuss about the recurrent lumbar canal stent. What is the blind spots? See this video where MIS fusion has been done at the 3-4 level, but there is a big blind spot which was remaining at this level, which is advantage is with the radio frequency probe we can directly go through the scar tissue and reach at the residual bone level at the canal stenosis at L45 level. So this is what I'm a very big fan of chisels. So I'm removing the bone pieces without entering the canal, by doing the bone work with this chisel, which I call as under the cave work, so that what you can do falling through the tights of the cave. So now you can see this virgin looking ligamentum flavum, which is yellow in color, so which was, I think, is a blind level left behind. So compromised culprit are nicely decompressed in this case. So here the inadequate shows with structures. The exiting route is see. This is the contralateral side, and you can very well see the exiting route on the contralateral side. Thank you so much.
Me how much flavum to be removed, I said 100% flavum to be removed. You see, you cannot imagine doing it with endoscopy. We did it with biportal. It is very rewarding. Biportal is always rewarding. So another level of 5 level, you see the case with the lumbar and dorsal compression. So both will be done with biportal endoscopy. I'll show you the last of the image. You can see everything, and she was very good after the surgery. How facets are preserved in the surgery, you see all facets are preserved.
Hello everyone, I'm Dr. Atma Ranjan Das. Because 4 and L5S1. The CT pre-spine surgery, you can see L34, 45 and 5S1 are completely stenosed. Right? You can see the 434 by moving to slow length. Extended the contralateral disc, started using the radio frequency probe to clean out the area of the annulotomy. so that we can P has been L3, and you the post-op CT scan, you can see at fusion at L for the post-op CT scan, you can see at 3 4 5 I have done a fusion, and you can see 3 4 4 5 5
Thank you, Dr. Atmaranjan. There was a slight technical glitches during the recorded presentation as well. I think we can call him online now. He's been patiently waiting, hearing his presentation in Google Meet. Can we get him on the screen? AV team, can we get him on the screen? He's been hearing if anyone has questions to him. Mute kar. Hello, Dr. Atmanjan, can you hear us? Hello. There seems to be some technical problem.
Hello.
Can you get him on the screen?
Hello.
Yes, can you hear us?
Hello.
Okay. Dr. Bamsi wants to ask some question to you.
Yeah, okay.
Yeah, Atmanjan, like, so you're very
Yeah,
passionate
visiting
about
here
it.
in Coimbatore.
Oh, is it? Okay. So
Yeah.
I was supposed to be there. Anyway, so you are always passionate about it, and obviously the stretching the limits of the UBE, like, I mean, very, heartening to see the kind of work that you're
Yes.
doing. And my thing is like about those multiple level decompressions, like in the old age patients, like you have shown those 5 levels and 4 levels of lumbar decompressions. So you are using the chiseling technique, like, is it
Yes.
because when we are operating on 80 years, the amount of saline, the time of surgery are the biggest concerns like that we have. And a lot of these people have scoliosis too, like, I mean, degenerative
Yes.
scoli and other things. So how we are kind of navigating these concerns, like, because what are the time periods and how the issues of bleeding and longer surgery hours and how the instability issues that we are looking at are being, because sometimes the scoli is a little tricky, like, I mean, the foraminal stenosis on one side, the other side is more scoli than they are bilateral, like when the issues are,
Yes.
how are you looking at these things?
So we have to understand, we as an endoscopic surgeon has a different perspective now altogether for degen scoli. We believe the degen scoli happened long ago, and it was a 70-year spine which God has little tilt on the thing. So there is no need to correct those osteoporotic fused spine to align, because that will cause a lot of pain in post-operative area. Spine is already stabilized in the wrong position. We can call it a malunion. So what we need to do is the neural decompression, because most of the patient comes with claudication, not with back pain. So the claudication we have to take care. So that is why what we do, we decompress the canal. So suppose we have a 4 level or 5 level and one side there is a scoli. In that case, we add para UB to it. Suppose left side L45 there is a scoli concave area, and you need to enlarge the foramen, so we can add a para UB to the multi-level decompression. And the timing of the surgery with this midline biportal endoscopy, what we have done, we have removed triangulation. This is a triangulation free UB which we are doing in a midline biportal endoscopy. So the time taken for the triangulation is gone. We triangulate in 10 seconds. To hold per level, our rough time is now around 15 to 20 minutes. Suppose you are doing for 4 to 5 level, roughly it takes around 1.5 hours max. That is because of the 0 degree scope which you are using and the chiseling. The chiseling makes the surgery very, very fast. And because there is a very less chance of progression of scoliosis after the surgery, because we in the biportal endoscopy, it's a muscle splitting. 2 5 mm incisions are more muscle splitting than a single 1 centimeter incision. So the muscle, interspinous ligament, all are preserved. And even the, all these facets, the study which we are showing, we preserve the facets by this caving technique. The question is how much facet you cut. We don't cut any facet. We just cave it so that it is flushed like a cone on both sides, so that the canal is decompressed wide like a tunnel in a cave, and simultaneously the integrity of the canal is maintained. So that is why we prevent a lot of progression of scoliosis. We are now coming up with a 2 years results of the canal stenosis will be soon be available for all of us. Thank you.
Good afternoon, sir. That was
Yeah.
that was wonderful presentation as always. So I had a query, like for going that extra mile to remove the extra phlegm and freeing the exiting root. So how can
Yes.
how can we make sure that we are not over drilling and we are not damaging the pass?
That is why this caving technique helps. So if you want to watch the whole video, that is there in my YouTube channel. So you can see we do not flush it. We don't see it like this. We see it like this, like a no temple, like a this cone. So when we go, we now, because we have been operating since long time, we know where the radiological, the endoscopic appearance of pars. So we prevent pars fracture. We just go under the cave so that integrity of the facet and pars junction is maintained. And in these cases of elderly, the bone is already fused anteriorly. If you see a CT, so every case we do a CT scan to access fusion anteriorly and all its sides. Most of these cases, the facets are hypertrophied. So we have to undercut and shape it so that it looks like a young facet. So that is how we prevent the integrity of the facet, just by going under the lamina. And we have to understand this scope in a biportal endoscopy is a 4 mm scope. So it can travel through the canal like a drone. So it doesn't have to restrict, just you have to cave so that the upper wall is removed so that the scope can squeeze in like this. Hello? Hello? Am I audible?
Hello. Yeah, Dr.
Hello.
Atmaranjan, you are audible, and thank you for your presentation.
Thank
We had wonderful exchange of ideas and knowledges over here. With this, I would like to end this session now, and we'll break for a short break, tea break for 5 minutes, and then we'll just a minute. Like I would like to request Dr. Balgopal to give token of love and appreciation to the, Professor Yang, and after that we'll meet for second session.
welcome back from the short break. Now moving on to the next session, which is the session of UBE step by step. May I request the chairpersons, Dr. Amol Rege, Dr. Amit Thapa, and Dr. Deepak Shrestha to kindly take their seats onto the stage and host the upcoming session. Thank you.
Welcome to the second session. Let me invite the first speaker, Suraj Thulam, on UB discectomy. Dr. Suraj.
Respected chairpersons, I am Dr. Suraj from UDM NINAS. I will be presenting briefly on UV discectomy. So this is the content of my presentation. So in history, in 1996, D. Anthony and Carlo M. L. was the first to do epidural endoscopy, followed by in 2001, Abdul Ghaffar did endoscopic lumbar discectomy. In 2003, Jean Hua Yum did unilateral endoscopy discectomy, and 2013, Jean Hua Yum did and Son did UV for lumbar stenosis. So in introduction, this is a versatile method of doing discectomies and other procedures. Basically, we use two ports, and the combined benefit of endoscopy and microsurgery can be achieved. So the indications being lumbar herniated discs, recurrent discs, spinal stenosis, spondylolisthesis, and even intradural extramedullary tumors can be taken out. Contraindications being infection, coagulopathy, some cases of degenerative scoliosis. Advantages being small incision, less muscle damage, there is continuous irrigation, so less bleeding, and there is a clear field. Basically there is a short hospital stay, allows good visualization of contralateral, sublaminar, and foraminal areas. There is faster recovery, less morbidity and complications. Generally, the used instruments are rigid endoscope, 0 degree and 30 degree, camera, light source, monitor, continuous irrigation system, working instruments like there is a Ranger, bore, RF probe, and shapers. In surgical stage, patients, we operate on prone position under general anesthesia, and special drapes with collecting bags systems are used. Fluorotherapy localization with basically with CM or OM. There are 2 incisions are made, triangulation are done, and irrigations. For irrigation, basically we use a gravity or low pressure pump, typically ranging 30 to 50 millimeter mercury, and creating a working space, a laminotomy done, discectomy, and hemostasis, and closure. For sting marking, first line will be on the midline, second line will be on the middle margin of pedicle, third line will be in the disc space. This line should form a triangle in the center of the spinal. And this is the diagram. Basically, there is 2 ports, 2 incisions, horizontal incisions, 1 to 1.5 centimeter, and basically 2 to 3 centimeter apart. And basically, triangulation should be converging, not averting in this way. And this is the triangulation docking on the spinal laminar junction, on the AP view, and on the lateral view. 2 ports are made, and then this thing irrigation channel, one is inflow of irrigation, one is outflow of irrigation. This is very we should have a clear outflow for, and this is a here this is a basically L4 L5 discectomy done from the left side. This is 6 o'clock position. This is 12 o'clock. This is 6 o'clock position. So this is spinous process. There is an infra-articular process. This is the lamina, which has two outer layer and inner layer. Outer layer is drilled, inner layer is drilled. Subsequently, then we take out the ligament flavum, starting from below and then going upwards. Ligament flavum is taken. This is a pictorial diagram, and this nerve root is being retracted medially. This we can see a thecal sac, we can see a disc space, and we can take out the disc fragment. So this is a video. Basically, I don't have the video of initial steps like triangulation and doing a bony workup. I have already gone inside. I have already done the bony work and play गरिदिनु पर्यो. So I have already gone inside. I have done a bony work. Laminotomy has been done. Ligament fibrin has been taken out. The nerve root has been retracted medially. This is the disc we have done for L4, L5 on the left side. Disc space has been explored, and we are taking out the disc. So after adequate decompression of the nerve root, we did a closure, we came out. So outcomes, it has high success rate, there is less post-operative pain, and there is faster rehabilitation. So common complications being dural tear. If there is a dural tear less than 3 millimeter, nothing much has to be done. If the dural tear is more, then we can just do like a bath plug technique, or we can just put some glues, even we can clip. And other complications being CSFD, cord injury, nerve root injury, hematoma, epidural hematoma, infection are rare because of the irrigation, continuous irrigation. There is other complications like incomplete decompression, hypothermia, headache, post-op neck pain, seizure, retinal bleeding might be due to excessive water pumping, and other complications being abdominal fluid collection. So to prevent this complication, there should be adequate continuous irrigation, optimal hydraulic pressure in the operative field around 30 to 50, and the scope should be near to the target, near to the nerve root, or near to the disc that we are taking out, and bleeding control should be can be done if the systolic blood pressure is around 100 millimeter mercury, and we use our RF for a short time, and we can use it repeatedly. So there are comparison, they are like with other procedures like microdiscectomy and UV discectomies. Here we use 2-port. There is a little muscle damage. Here the recovery is fastest. So in the take-home message, UV discectomies are safe and effective, minimally invasive. There is comparable outcome with the conventional surgery. They have an advantage like better visualization, less muscle trauma, and has faster recovery. Thank you.
Thank you, Dr. Suraj. Excellent talk. Any questions from the floor? Yes. Can we have a mic?
Very nice presentation, Dr. Suraj. I'm Dr. Vishnu from Army Hospital. So how often you do aneuplasty after removal of the disc in case of UV discectomy?
We oftenly do, just to prevent reorganization of the discs.
So you regularly you do the aneuplasty?
Yeah.
Thank you.
Can I ask you a question? For the right-sided disc, you go from the left or right?
Right side, sir.
You prefer from?
Right side, because I'm right-handed surgeon.
Anybody for the right disc pathology they do from left side? Can we have a raise of hands? I think most of them are doing from the. Okay, thank you. Can I invite the next speaker, Dr. Raju Pandit, UB discectomy early experience. Can I request Dr. Thapa to present Dr. Suraj? Dr. Raju Pandit.
Good morning, everyone. This is my early experience with UB Discectomy Institute and Allied Sciences. I am Dr. Rajiv. I am a neurosurgeon. So I have nothing to disclose. So why UB for me? So early exposure with laparoscopic procedure and UGI endoscopic during my general surgery residency attracts me towards the endoscopic procedure in neurosurgery. And this is a very new and different dimension that which we are doing in Nepal for neurosurgical procedures. And of course, very few persons are practicing in Nepal, so I have determined to take it to a next level in UB surgeries. So what are the benefits of doing UB surgery? So the posterior anatomy is more clear and the vision of field of vision is more wide than as compared to the open surgery. The postoperative pain is very less. It's like a daycare surgery. We can discharge the patient on the evening of the surgery. And of course, there is minimal soft tissue injury for the major cases, and we can perform bilateral decompression while staying on the unilateral side. And of course, we can do fusion, fixation, the major cases, with the minimal injury to the soft tissue. So my UV experience starts with observation at Manipal Pokhara with Professor Balgopal Karmacharya. Thank you so much, Professor Balgopal Karmacharya, for this opportunity to learn UVE. I have opportunity to see the cases and to find my hand-eye coordination, which I have during laparoscopic surgery, during general surgery, and where I practice on goat spine so many hours. And the next observation and learning at Ninas with a person who has done the most number of UV surgery in Nepal, Dr. Nikunj Yogi, and then cadaveric workshop. So till now, I have done only 5 cases at Annapurna Neurological Institute and Allied Sciences, which was last 1 month, and all were discectomy. One was right-sided, rest were left-sided, and all cases were lumbar disc herniation. One case I had to open because I could not stop the bleeding. So everyone says that if you are a learner, if you are a beginner, you should start with the left side and 4 and 5, L5 and S1. But I got opportunity to start on the right side, and which was L4 and L5. And it took me around 4 hours to complete it. I'm very happy with that first case that I have not opened it, and I have completed successfully. The patient is in the follow-up, and he is very happy. He is pain-free. So the ward setting, the patient is on prone position with rolls, or we can place on the Wilson's frame also. The surgeon on the side of the disc, whether it's right or left, we should stay on the side of the disc. A scrub nurse on the same side, on the left side of the surgeon. Assistant on the opposite side to retract the knob root and the thecal sac for discectomy. Monitor on the opposite side, of course, to see the visualization. And irrigation, already talked so many times in the previous talks. And C-arm should be on the cranial side. Usually what I do is when I triangulate and then I remove the C-arm because I don't need later on. So it's very easy to work. So this is the first initial C-arm, the X-ray we should do. This should be a squaring of the index vertebra. And here we can see the spinous process, the lamina, and the interlaminar foramina or space. So our target is the base of spinolaminar junction, and our entry is the medial inferior pedicle line, which you can see here on the red circles. The upper one is the upper pedicle, lower is the lower pedicle, and the distance between the 2 entry points should be around 2.5 to 3 centimeters, so that we can converge the both ends at the spinolaminar junction. For the initial few cases, it's better to have a longitudinal skin incision, so that if we have to open, we can connect the both ports. And the facial incision should be oblique, as shown in the picture. So triangulation at the base of a spinolaminar junction is the basic step in UBE surgery. So bone is the best friend in endoscopic surgery. Once we see the lamina, we should land our RF probe over the lamina and start stripping the soft tissue from the lamina. So handling the scopes, it's better to start with the 0-degree scopes, as already talked in the previous talks. It's the orientation and the depth is also better with the 0-degree scopes as compared to the 30-degree. And the scope should always be on the left hand. So for a right-handed surgeon, it's better to have a scope on the left hand, and so that we can work with the working ports on the right side. The laminotomy is done with drill, saver, or the Kerrison punch. I don't have saver, I use drill. NSK we can use, we don't have to buy an extra drill for endoscopic surgery. And of course, irrigation, multiple times we have talked. It should be at the level of head, just above the head, so that the pressure is maintained about 30 to 40 millimeter of mercury. So once the lamina is, once the ligamentum flavum is seen, we should try to reach the proximal attachment of the lamina so that we can strip out from the original attachment of the flavum. And flavum is removed with the help of Kerrison, discectomy, or knob hook, and then the root is retracted and discectomy is performed. The flip side of UBE is there is a long learning curve with triangulation and hand-eye coordination. Of course, there is the investment, new investment with the RF generator, scope, and drill. Of course, there is the chances of injury, there is chances of damage to the scope in the early stages, as we don't know how to play with the instruments. And yeah, there is a frequent loss to the orientation to the instruments if we take it out multiple times. So better to keep inside and try to coordinate inside. Of course, bleeding is the main issue that compels us to open it. So try to have a patience, and we can control the bleeding. And there is the chances of injury to the thecal sac and the nerve roots, which is barely visible in endoscopic views. And of course, fluid-related problem is there, like tissue edema, seroma, which can lead to infection. And the time for us, it's like a bomb for us. It can burst any time, so that we can open